Going to the next presentation. This is a spinal cord injury classification and managing acute complication by Dr. Zachariah.
Thank you, Dr. Munal and Dr. Venu, for giving me an opportunity to share some thoughts on spinal cord injury classification and managing acute complications. So, what is classification? Classification is the act of putting people or things into groups or classes. And it is the process of systematically arranging things in groups or categories based on shared similarities and differences to make them easier to study, compare and understand. So that is the basic of classification. And in assessment in spinal cord injury, our textbook on PMR says that it is the assessment of an individual suspected to have spinal cord injury at the trauma ward is different from the assessment at the rehabilitation ward. So when you're seeing an acute case, it's different. When you're seeing at the rehab ward, it's different. So while a quick and rapid survey is required for the former and a comprehensive and systematic history, clinical examination and functional assessment are prerequisite for the latter. The ICF framework is used for the assessment, goal setting, planning and monitoring of the rehab services that is in the rehab ward. So when you classify grouping into things, when you're looking at anatomically, you can classify it into cervical, thoracic, lumbar and sacral. If you look at causes, you can divide it into traumatic and non-traumatic. If you take up non-traumatic, you can again classify it into infective, inflammatory, vascular, metabolic, degenerative, neoplastic, idiopathic and miscellaneous. Infective, tuberculosis, bacterial and viral infections. Inflammatory, again transverse myelitis, multiple sclerosis. Vascular, thrombotic. Metabolic could be diabetic, letharism. And neoplastic, which can be extradural, subarachnoid, extramedullary and intramedullary. So the classification is just for grouping purpose. And classification, when you do according to the area of lesion, it is anterior cord syndrome. It will be motor predominant. Central cord syndrome, upper limbs are more involved, but with spasticity. Brown-Sequard syndrome has a hemiparalysis-like picture. Posterior cord, you will have ataxia-like picture with loss of posterior column. Then you have Connors-Cauda syndrome, where the bladder is involved and you may have a sort of symmetrical partial lower limb paralysis, whereas in Cauda equina you will have an asymmetrical with an element type of bladder. So when you look at traumatic spine, that is, if you look at the spine, then you can be either stable or unstable. And Francis Dennis has come up with a good classification, that is you all know about the 3-column concept. You have the anterior column, which is the anterior longitudinal ligament and the anterior 2/3 of the vertebral body. The middle column, which is the posterior 1/3 of the body and annulus. The posterior vertebral wall and posterior longitudinal ligaments. And the posterior column is all structures posterior to the posterior longitudinal ligament. So based on this, it is basically to determine stability, to guide treatment and to assess the prognosis. And based on this, the fractures have been classified into compression, burst, flexion, distraction, which is a seatbelt type of injury, and the dislocation. So compression, it can be anterior flexion and anterior and axial loading. You can have a non-operative treatment for it and an operative treatment for it. The non-operative is bracing and vertebroplasty and kyphoplasty, and operative is posterior instrumentation. Burst, again you can have a non-operative. This is why we classify, to help us make a better decision. Non-operative and operative, non-operative is bracing and operative again instrumentation. In flexion distraction injuries, again non-operative is bracing and operative is posterior instrumentation with or without fusion. So flexor distraction, you need to have some fusion. And in dislocation, can have shear, rotation, compression and tension, and it's usually operative decision. But many of our patients may not be able to afford it or may not be able to access it. So you still have to go back to some non-operative even for that if access is not there. AO has spine classified into type A, which is compression, type B distraction injuries, and type C, which is displacement and dislocation injuries. And again type A has been divided, but we need to know that these are the different types. Thoracolumbar injury classification and severity score is also there for thoracolumbar injuries. It assists in predicting stability of the fracture and to guide treatment. When you come to functional classification, the common ones are the Frankel's classification and the Asia impairment scale. And we started with the Frankel's classification, and it was more clinical and more, I'm not saying more clinical, it was more descriptive to what the patient felt. So, complete A is actually motor and sensory loss below the segment mark, which I think all of our students know. B, again some sensation was present below the level of lesion, but the motor paralysis complete and with sacral sparing. The 3 is actually, they have, the Frankel used to say this motor useless power was present below the lesion, but is of no practical use. And motor D is again motor useful, there was useful motor power below the level of lesion, and the patient could move the lower limb and many could walk with or without aids. And E was actually recovery, where the patient becomes free of neurological symptoms, but abnormal reflexes may be present. So, this Frankel actually evolved into our Asia classification, that is international standards for neurological classification of spinal cord injury. The 5 steps are the determining the sensory level both for the right and left, determining motor level for right and left, determining neurological level, finding whether the injury is complete or incomplete, and Asia impairment scale grading. So, first the key sensory points, 28 dermatomes was assessed for pinprick and light touch and graded 0 absent, 1 altered and 2 normal. And the most caudal spinal dermatome with a normal sensation is identified as the sensory level, where the right and left can differ. So, we sometimes have arguments on it, which is the level and which is not the level. So, I think it's a most caudal level with the normal sensation. That's what the books say. The next manual, next what we do is a manual muscle testing of the key muscles, the 10 myotomes, C5 elbow flexors, C7 elbow extensors, C6 wrist extensors, C7 elbow extensors, C8 finger flexors, T1 finger abductors, L2 hip flexors, L3 is knee extensors, L4 is ankle dorsiflexors, L5 is long toe extensors, and S1 is ankle plantar flexors. So, again the most caudal muscle of at least grade 3 strength with intact grade 5 proximal muscle and the muscle key, and the key muscles is identified as the level, and the levels may again differ in right and left. So, next is the neurological level is decided is the most rostral segment of the above, that is 4 of what we have assessed, that is right, left, both sensory and motor. And you determine whether it is complete or incomplete if there is sparing of the function of the sacral segment. That is the sensory testing of the S4, S5, the voluntary anal contraction and the deep anal pressure. So, finally, the Asia impairment scale grading is determined from grade A to grade E. So, A and B are almost the same as in Frankel's. But in C, it is incomplete, motor function is preserved, it has become more detailed and more objective with more than 50% of the key muscles below the neurological level of injury, which have a muscle power of grade less than 3. And in incomplete, when motor function is preserved, but at least 50% of the muscles below the level of injury have a grade more than or equal to 3. Sometimes again we have arguments on whether it is more or equal to 3. So, in normal, motor and sensory functions are normal. So completeness is again decided as per sacral sparing, complete or incomplete, and you can also classify it into tone by dividing it into spastic and flaccid, and according to limb involvement as paraplegia and quadriplegia also. This is just a grading, it's not a classification, but you can grade ambulatory for spinal cord injured patients by Hofer and Bullock. That is, grade 1 is community ambulation, grade 2 is household ambulation, grade 3 is physiological ambulation, grade 4 is wheelchair independent, grade 5 is wheelchair dependent, and or let's say assisted wheelchair, and grade 6 is recumbent. So this just gives us an idea of how his ambulatory potential. So when you come to diagnosis writing, we actually follow this. That is the level of the neurologic, the T12. Then again classify it into spastic or flaccid, then complete or incomplete, then either paraplegia or quadriplegia, then according to Asia grading, and then you also describe the fracture that has occurred to the spine, that is T9 burst fracture, or whether it is surgically fixed. Coming to the acute complications that I have to say, of the many forms of disability which can beset mankind, a severe injury or disease of the spinal cord undoubtedly constitute one of the most devastating calamities of human life, by Sir Ludwig Guttmann, who was one of the fathers in spinal cord injury management, and hence the best treatment still continues to be prevention. So you must ask most people to continue wearing your seat belts, drive safely, and when climbing trees also to hold well before you leave the next limb to catch the next branch. Because what usually happens in climbing trees is also when they get excited, they may hold it and then shift their hand onto that without holding, and then they can fall. And when coconut tree climbers climb up to the tree, sometimes you have a wasp stinging you, and you can have, but I have talked to some of them, and some of them said even whether if the wasp bites or the ant bites, you still won't never give, will not let go of the grip. So I think if we advise them to be a little bit more careful, that then you can also prevent some spinal cord injuries. So spinal cord injury management requires a multidisciplinary team approach and should start with first aid at the site of accident and last till the patient is successfully integrated into the community. This was by the white paper on spinal cord injury for Indian Orthopedic Association. So Chabras said that this is some 10-15 years back. So after the neck is stabilized, the patient is moved to a supine position by 4 persons on a spine board to a hospital and to a definitive center that specializes in managing spinal injuries. The high tetraplegic may require special attention since they could have a respiratory arrest and may require ventilation. And the role of steroid is inconclusive. And the prophylactic anticoagulation therapy is routinely used in all high risk patients, and early mobilization of the lower limb is needed for preventing DVT along with anticoagulation, and surgical management is usually indicated in the most unstable spine fractures. And bladder should be managed by indwelling catheter during spinal shock, and indwelling suprapubic catheterization is preferred for tetraplegics in the long term, and a bowel evacuation program, which is what we usually tend to forget, should be instituted at the earliest to prevent its complications. And aspiration, atelectasis, pneumonia and ventilative failure are some of the common causes for death from the respiratory, and these are prevented by early nasogastric aspiration, proper pulmonary toilet and supported ventilation. Pressure ulcers are prevented by regular safe turning over, and skin care is avoided, and good support surfaces to be given. From our old rehabilitation medicine textbook of Good Gold, which actually became Delisa, I think so, After a spinal cord injury, patient arrives at the acute care hospital, medical stabilization is first achieved, and this includes treatment for shock, stabilization of the cardiopulmonary issues, catheterization of the urinary bladder, treatment of the head and other injuries. So sometimes people tend to forget about other injuries which should also be addressed, and imaging and evaluation of the spinal fracture, and a decision for surgical stabilization is made. The invasive methods they have he said is cervical fusion, and non-invasive was continued traction, halo traction and collar. Cardiopulmonary monitoring is essential for the quadriplegic and the high paraplegics, and if there is no medical contraindication, suggest a low dose heparin. Intermittent positive pressure breathing or incentive spirometer should also be used, and log rolling, stress ulcer management, and adequate IV hydration and antibacterial therapy. So the common complications that are seen are neurogenic shock, bradyarrhythmias, hypotension, autonomic dysreflexia, abnormal temperature control, respiratory complications in high spinal cord injury patients. Bladder complications are retentions and infections, and constipation and bowel complications. In neurogenic shock is there in 19% in cervical injuries and about 7% in thoracic injuries. Achieving hemodynamic stability ensures adequate spinal cord perfusion. So IV fluid resuscitation, and prolonged and severe hypotension will require vasopressors for about 5 weeks. Atropine they have used for bradycardia, and stabilizing the spine is one of the most important thing. One of my experience in spinal cord injuries, we had a quadriplegia who was treated conservatively. Even after 3 months, the person, I think, sat up. We had advised Philadelphia collar, but he sat up without the collar, and then he went in for respiratory complications suddenly, and I think I don't remember it. I think we lost the patient also. So stabilizing, keeping the spine stabilized is important for not moving maybe. Just that part alone is important, and maintain mean arterial pressure of 85 to 90 for adequate spinal cord perfusion. Airway management, 67% of the acute spinal cord injury have respiratory complication, atelectasis in 36%, pneumonia in 31%, and respiratory failure about 22%. And there is a 30 to 50% reduction in vital capacity for C5, C6 in the first week. So you may have to give supplemental oxygenation and supported ventilation. Hemodynamic support, Asia A and B, 68% of the cervical lesions have hypotension. You have to manage with IV fluids, vasopressors and inotropes as needed. And maintaining the mean arterial pressure between 85 to 90 is important. Abnormal temperature is also an issue due to reduced sensory input to the thermoregulatory centers and loss of sympathetic control. You can have temperature issues, and poikilothermia is possible irrespective of stable ambient temperature. So poikilothermia is actually, we see it in lizards and snakes, because their temperature will go up and down, but when sympathetic control is cut, then you can have poikilothermia. So even if you have a stable ambient temperature, the patient can have issues of temperature variation. So you have to monitor, continue maintaining an ambient temperature and manage with warm blankets or cold compresses. So bladder retention, Foley's catheter, you all know, is essential for monitoring and decompressing the neurogenic bladder, and also to monitor the shock and the hypotension phase. So stress ulcers, you must man prophylaxis with proton pump inhibitors and sucralfate. And cardiovascular issues, that is during acute stage of cervical cord injury, bradycardia and sinus arrest can occur, maybe due to sudden loss of supraspinal sympathetic control of the heart, while the parasympathetic vagal system is intact. So bradycardia is there in 64%, Muscular paralysis with flaccidity in the initial stage can reduce venous flow and can also result in hypotension. And hypercoagulability, because of the blood flow issues, you can have hypercoagulability and again predispose the patient for deep vein thrombosis. Autonomic dysreflexia, I think Sri Kumar sir will take these classes. It's a life-threatening conditions. Pain, pressure, bladder retention, infection, ingrowing toenails are the causes, and the BP goes up to over 200. I'll just skip it. So psychological stress, we tend to forget that this is important, and you may sometimes have to manage it with drugs. So my references are these, and to conclude, you must stabilize the spine, manage and secure the airway, meticulous monitoring, addressing neurogenic shock. Meticulous monitoring is what is important, because that will pick up the complications far earlier. Vasopressors or inotropics as needed, nasogastric aspiration in paralytic ileus and to prevent aspiration, and prevent pressure sores, catheterize the bladder. And newer drugs I've on the AI Google, I saw Riazole and Minocyclone. They say it protects the cord. I'm not sure about it. So to conclude, classification, Asia impairment scale is what we use. But don't just look at only the points, look at the meaning, as what Frankel has said. Acute complication must be picked up early, regular monitoring, treating acute complications early, and get help if you find it difficult. That is what is more important. So prevention is always better than rehabilitation. Thank you very much.
Thank you, George Sack. Any questions, comments?
At least 99% of you are getting this case in your final examination. 99%. Only 1% will get a stroke. So this is the most important presentation, I think. And thank you, Zachariah sir. And one question I would like to just share with you, which we ask as an examiner: what is vertebral level of injury? What is anatomical level of injury? What is neurological of injury? I think you all are familiar with all these three questions, and I hope you know how to answer these three questions: the vertebral level, the anatomical level, and the neurological level. Just to know how much you know about these labels, and to get sometime confuse you, we ask these questions. So be clear about these questions and how to answer that.
Scan this code and provide the feedback. I'll change the headings. Any other comments, questions?
Can I take a disclaimer? No, I'm not into acute spinal cord injury for the past some 15 years, but I can try to help you.
Good morning, everyone. I'm Dr. Vishas. I'm JR from AIMS, New Delhi. Sir, if a person has voluntary contraction is present, but the sensation is not present, so will we classify it as ACRC, or how will you classify it accordingly? Like, sensation is not in the S4, S5, DAP is also not there, but VSE is there.
Yeah, but then sensation is a part of the sacral system, and then you can consider it as you're not having sensation.
Yeah, we are not having sensation.
Yeah,
but
even if either sensory or motor. So what I would go is, I would tell it as complete.
No, sir, VSE is there. DAP is not there, S4, S5 sensation is not there.
Yeah, but because S5, S4 sensation is not there, the sensory nerves have been affected.
Yes, sir.
So that's when I would consider it as complete, but I think...
Any other questions?
I would just like to add, thrombosis of the spinal cord should be treated, and it actually is very rewarding, because if you get spinal cord, if you treat him well, I have seen paraplegics come back to walking.
It is the thrombosis of the
Adam Kivitz, whatever.
okay, yeah. So